You're familiar with this, correct? Henry talked to you about how we get there. I'm going to talk to you about the end stages of the disease, which really are what we deal with. In the office, you deal with the early stages of the disease, preventing its clinical manifestations. On the other side of the street, in the hospital, you deal with treating the disease and minimizing it, or obviating its clinical manifestations. So Henry taught you how we got here. Despite our best efforts, some people get here. And these are two illustrations of disrupted plaques. We talk about plaque rupture. That's probably not the only target we're looking at. There's a concept called plaque erosion that we don't have time to talk about, which is good because I don't know a lot about it, other than that it's more common in women, drug users, and those with non-ST elevation infarct than ST elevation infarct. But in general, the more severe the disruption to the plaque, the more likely that thrombosis is going to occur. So remember, you live with atherosclerosis, you die of thrombosis. And most of the time that thrombosis occurs biologically, sometimes it occurs iatrogenically. So conceptually, at least, when we inflate balloons, when we instrument the vasculature, we introduce injury to the vessel, we introduce foreign bodies, we basically put out pheromones that attract the coagulation elements from that circulate. Okay, so this slide encapsulates a lot of concept, a lot of mechanisms we're not going to discuss briefly. The only point I want to make here is this. Most of the time we think of platelets as things that stick together and cause clots because they form a barrier, right? That's partly true. It's largely untrue, though. Platelets are rapid responders through the glycoprotein IIb/95 complex. They respond to changes in shear stress. They land very quickly at sites of arterial injury, and then they coordinate the coagulation response. So they call in other platelets. They also undergo changes during activation that establish a foundation for the soluble coagulation system to become activated. So without platelets, it's very tough to form clots of any type. Red clots or white clots are all dependent on platelet activation and changes in the cell surface. We're not going to talk about that, but it's important to remember. Largely, this is nuts and bolts, so we're going to talk about the treatments. So start at the beginning of coagulation. What are the effective classes of antiplatelet therapy that you and I have to deal with? Well, going back, way back, to the early 70s, there's aspirin. Aspirin, for a long time, was the only established treatment that saved lives and prevented heart attacks in people with atherosclerosis. This is before bypass was established, certainly before fibrinolytic drugs were established, before primary PCI was established, way back. Aspirin is now under question because we're starting to get redundant with other classes of medication. But aspirin is an antagonist of cyclooxygenase 1, not cyclooxygenase 2, so you're taught, but there probably is a little bit of interaction. And its role is to block amplification of the platelet response. ADP, P2Y12 receptor antagonists, we think of them as anti-aggregants. They are. For a long time, people said, well, these are oral 2B3A receptor antagonists. They're not. They largely prevent platelet activation by ADP, but if you look in detail at some of the intracellular mechanisms, ADP response amplifies platelet response to other stimuli. And we'll talk a little bit more about them. Glycoprotein 2B3A antagonists. We will talk about those. Those are, by and large, strictly anti-aggregants. They don't inhibit platelet activation. They may even cause platelet activation to a certain extent through what's called outside-in signaling, but largely they block what's called the final common pathway of platelet aggregation. Now, when you get right down to it, none of these things I'm telling you are absolutely true, but they are mostly true. Platelets really can't aggregate if you block the 2B3A receptor, which, in cardiology parlance is now called the glycoprotein receptor. You'll see the abbreviation GPI used. I would discourage you from doing that because at some point we're going to get glycoprotein 1 antagonists, and then we're really going to be in a mess because we're going to be given wrong orders and writing wrong stuff all over the place. And PAR1 antagonists. These are the platelet thrombin receptor antagonists. There's one available known as Vorapaxar. Who's ever written a prescription for Zontivity? Yeah, okay, me neither. It's been out for a year and a half. No one in the room has ever given it to a patient. I've never seen a patient on it. Although, we're still very optimistic about drugs in this class, which, proves that this stuff's getting confusing as we pile drug upon drug upon drug. Okay, aspirin irreversibly inhibits COX-1, which formerly is known as prostaglandin GGH synthase, and prevents formation of the vasoactive and proaggregant compound thromboxane A2. As of this year, 2016, if you have coronary artery disease, you're on it indefinitely. It probably is not indicated for primary prevention. Now, if you look at the primary prevention literature, you start stacking the studies together, the odds ratio always hovers around the line of unity, and every 6 months it switches a little bit one way or the other. So I tell patients, look, if you really want to be on an aspirin a day for primary prevention, you take it during the 6 months when the studies are positive. When the next study comes out, stop it, wait for the following study to restart it. It just tells you for primary prevention, your mother asks you, should I be on an aspirin a day? If she doesn't have atherosclerosis, the answer is no, because it's balanced by the risk of bleeding. They're both low. The preventive benefit is low, the risk is low, but they balance out a little bit toward the negative for primary prevention. The optimal dose is 81 milligrams a day. If you work at Methodist and you put someone on 325 a day, I'm going to smack you around, period. In 2016, there are a number of investigations underway to try to drop aspirin from multi-drug regimens. And why is that? Well, nothing fancy, but, it doesn't have a sponsor, it doesn't have a proponent, and it's cheap. No one makes a profit from aspirin. Who the hell's going to defend it? We'll see how that plays out over the next several years. Okay, platelet purinergic receptors. This slide shows you the ADP receptor. Get that out of your language. There is no the ADP receptor. On the human platelet, there are 3 purinergic receptors. They all respond to ADP. The one we work with is P2Y12. Last time I checked, there were 14 P2Y receptors in the human body. This is the target of the active metabolite of the phenylpyridines, Clopidogrel, ticlopidine, and prasugrel. It's also the target of the actual drugs, ticagrelor and cangrelor. A little bit of bottom line. Phenylpyridines are prodrugs with irreversible binding. So they're metabolized in the liver through several stages. They become active metabolites, which are relatively short-lived. So although they stick to the platelet once they're there, so their biologic half-life is long. Ticlopidine, Clopidogrel, and prasugrel. The non-phenylpyridines, drugs that have direct, short-acting, reversible binding, ticagrelor and cangrelor. They attack different sites on the receptor. As you know, and you've heard ad nauseum, because there's a lot of money in this, variability in the clopidogrel response. Very well documented. Every study that's looked at it has shown it. We've seen it, when I first started showing the our findings to people, they said, put that away. You can't say anything bad about Clopidogrel. Well, someone else did, and really it's absolutely true. This is variability in response to a pretty hefty Clopidogrel load. And in fact, there are multiple studies that show that if you are hyporesponsive to Clopidogrel and you have either had a stent or an acute coronary syndrome, you're at higher risk for a recurrent event if you're on Clopidogrel and your platelets don't respond to it. Now, it's not a platelet problem, it's a liver problem. You don't metabolize it effectively to its active metabolite, and that, in most cases, is largely due to a mutation of one of the cytochromes, CYP2C19. About 30% of the Caucasian population, 10% more so, 40% of an Asian population, about 50% of an African American population. It's serious stuff. Now, there have been studies done to look at replacements, or rather treatment based on this finding. So far, none of them have been positive. Zero. For various reasons. They're all lousy trials. It makes sense to do something different in these patients, but so far, nothing has been shown to work out. This is not the evidence of absence. This is the absence of evidence. The trials are pretty poor. So bottom line for P2Y12 antagonists. On top of aspirin, ticlopidine is better. This is ticlopidine than either after warfarin or aspirin alone in patients who've received stents. This is stuff that's 20 years old now. In patients with stents, treatment with a P2Y12 is absolutely mandatory. Minimum of a month after bare metal stents, minimum of 6 months for drug-eluting stents. The optimal duration of therapy isn't known. Again, we're at the mercy of clinical trials. Actually, some of them show that 3 months is adequate. Between 3 and 6 months, no difference. So maybe after 3 months, you ought to stop it. But then 12 versus 30 months, there's a benefit for 30 months. So stop it for a few months and then restart it. Again, this stuff takes a lot to synthesize. To make a long story short, probably a minimum of a year is required. Maybe it's 6 months, maybe not. But there is some point between 6 and 12 months when you've got to ask yourself, how well is this patient tolerating his P2Y12 antagonist? If they've had stable angina. If they've had acute coronary syndromes, it's probably better to go out 12 to 15 months. P2Y12 antagonists do cause increased bleeding during cardiovascular surgery. So the guys in the other rooms don't like it. When possible, Clopidogrel should be stopped about 5 days before, probably the same for ticagrelor, Prasugrel 7 days before. More data, no data, more information. If you load someone with Clopidogrel, these are the official times it takes for the drug to be active. Now, as you know, there's a lot of biologic variation around this. So for Clopidogrel, we are taught that 600 milligrams reaches its peak effect within 2 hours. That's what the dose we give to people with stents. 300 milligrams, 4 hours, 75 milligrams, 24 hours. What happens if you have a Clopidogrel overdose? Omar. Well, it doesn't get metabolized, so you end up with expensive feces. It just goes through the intestine, it's bottlenecked in the liver, you can't overdose on this stuff. Okay, Prasugrel and ticagrelor. The indication in 2016, ACS, period. Now, do we all do it, use it in other patients? Sure we do, but these drugs have never been tested outside of acute coronary syndromes. Before the angiogram, ticagrelor only. Prasugrel has been tested upstream before angiography, no benefit. Why should that be true for one drug or not another? Everybody's got an idea. The truth is no one knows. Maybe ticagrelor got lucky and Prasugrel didn't. We don't know, but if you use Prasugrel upstream, you're out on a relatively thin limb. Prasugrel also has boxed warnings. So this is the so-called black box. The FDA has decided you should use it either not at all or exceptionally cautiously in patients with prior stroke or TIA, age greater than 75, weight less than 60 kilos. Why prasugrel and not ticagrelor? Again, did one drug get lucky and one unlucky? We don't know, but this is the evidence we have in 2016. Okay, GP2B3A antagonists. GP2B3A, which is correctly known as integrin alpha-2b beta 3, is the platelet receptor for fibrinogen and several other macromolecules. Mediates platelet aggregation via binding to fibrinogen and several other molecules. There are 60 to 100,000 such receptors on the surface of each platelet. We are over time, so I will just tell you that there are 3 antagonists available. Abciximab or Riopro, which is a monoclonal antibody, very short plasma half-life, but really sticks to platelets very avidly. The peptide, eptifibatide, and the peptidomimetic tirofiban. Their use has declined considerably over the last decade because we got better stents. We've got Clopidogrel and other P2Y12 antagonists, and mostly because we're better at doing this stuff. It's now used largely to treat intraprocedural complications of PCI. Remember, it requires a reduced dose of heparin and possibly of bivalirudin. Bivalirudin has a bleeding advantage over heparin. It may be obviated in patients who get GP2B3 antagonists. You may no longer have that advantage. A word about heparin. Heparin's a polysaccharide derived from animal sources, largely cow intestine. It's a biologic. Therefore, there's variability from batch to batch. What you get in a vial of heparin contains many different sized molecules, only 1/3 of which are biologically active. Heparin promotes binding of antithrombin to factor Xa, amplified by about 1,000-fold, and is mediated by the essential pentasaccharide. There's also direct anti-2A activity mediated by an 18-saccharide sequence. If you want to pimp the interns and residents that round with you, ask them the difference between antithrombin 1, antithrombin 2, and antithrombin 3. Who knows the difference? Great. They're the same molecule. So it's called antithrombin. The anti-2A to anti-10A ratio is 1:1 for unfractionated heparin. It's about 1:4 for enoxaparin, so much more anti-10A activity. Fondaparinux, the ultimate low molecular weight heparin, has only anti-10A activity. Heparin has a negative charge that facilitates reversal by a drug called protamine. How do we dose heparin? Well, for ACS, we measure the APTT. Laboratories like anti-10A levels, but the truth is, for what you and I do, there are no data, zero, to tell you what an effective anti-10A level is for a patient with unstable angina or a myocardial infarction. But the laboratories love it because it's reproducible. All the data for anti-10A levels involve treatment of venous thrombosis. Bivalirudin, small peptide, 20 amino acids based on hyaridin structure. So hyaridin is 65 amino acids long. Bivalirudin is 20 amino acids long. It's unrelated to heparin. It binds the active site of thrombin. It's got an excretion half-life of 30 minutes. The excretion is renal, so the dosing does have to be adjusted in patients with severe renal insufficiency. It causes less bleeding than combination heparin GP2B3A antagonist. It is indicated for PCI, possibly for ACS, but it's expensive stuff. So if you're going to keep someone on an infusion for 24, 36 hours, you're going to be spending a lot of money. That's generally the reason we don't do it.